Welcome to NU 623 Adult Healthcare, Unit 8, Presentation 3. This presentation is going to cover testicular disorders. I ask that you read the corresponding chapter for additional and required information about this disorder. This presentation is meant to be an adjunct to the textbook. It is not comprehensive, rather a brief outline of selected material. Additionally, I would like for you to review any course links in your module. With epididymitis, subjectively there will be gradual development of scrotal pain and swelling, with possibly pain at the tip of the penis, urethral discharge, or urinary tract infection-like symptoms. Fever and chills occur with severe infection. The patient may report relief of pain with elevation of the testes. Objectively, you would do a thorough GU and rectal exam, assessing for scrotal edema, thick and indurated scrotal wall, nodularity of vas deferens, tender epididymitis, and prostate. Differential diagnoses are varied, but testicular torsion is a urologic emergency and can be ruled out if the cremasteric reflex is positive. Diagnostic tests to perform include AUA, which will be positive for pyuria and leukocytosis. Culture of penile discharge or urine for chlamydia and gonorrhea can be done, which is the most likely cause for infectious causes in men under the age of 35. A CBC would show increased white blood cells with a left shift. An ultrasound of the scrotum can be done to confirm this diagnosis. Non-infectious causes are treated with supportive care. Infections for men under the age of 35 with sexually transmitted infections, empirically treat them with ceftriaxone and doxycycline due to the most likely causative agents. If allergic to cephalosporins and tetracyclines, then a fluoroquinolone can be given while you're awaiting cultures. Older men or those without the risk of a sexually transmitted infection can be treated with Cipro or Bactrim. Infections will receive the same supportive care. Sometimes surgical procedures are needed to drain a hydrocele or an abscess. In severe cases, surgical procedures may be needed. Follow-up may be for several weeks due to the fact that the testes may stay indurated that long. Urology may need to be referred to for surgical procedures or refractory treatment. Health departments should be notified for positive sexually transmitted infections. Testicular torsion is more likely to be seen in men under the age of 20, but it is a urological emergency. It must be fixed within 4 to 6 hours. Testicular torsion usually presents as acute pain and swelling. However, if the appendix testis is in torsion, it may be a gradual onset over several days. This presentation may also show a small palpable lump that is blue when the skin is held taut. Differential diagnoses are varied and some are more urgent than others to rule out. Testicular torsion can be diagnosed by the history and exam findings initially. However, a color Doppler ultrasound should be done if it is in within the first 12 hours. If it is not, then you should do a radionuclide scan. They can be used to diagnose a testicular or appendix testis torsion. A decreased or absent pulse will be noted with torsion, but increased flow will be seen in inflammatory processes on ultrasound. The nuclear scan will show absent or decreased vascularity with testicular torsion and increased vascularity if it is an inflammatory process or appendix testis torsion. Manual reduction can relieve the pressure and may be successful, but surgery may be required to restore blood flow or to remove a non-viable testis. Surgery should be done within 4 hours. Testicular torsion requires immediate urologic referral. Given the time frame that the testis can remain viable, it is best to refer the patient to the emergency room. The patient may then be followed by urology as needed. Hydroceles can be acute or chronic. The clinical presentation, both the patient history, which is your subjective data, and exam findings, which is your objective data, can be seen on the slide. It's also important to obtain any history of trauma, recent scrotal infection, or radiation therapy. Notice that the differential diagnoses include hernias, inflammatory, infectious or testicular trauma, or vascular causes. Please read your textbook on page 772 to help understand the differentials better. Diagnostic tests are not typically needed as this can be a clinical diagnosis, but if unsure, you can get an inguinal scrotal ultrasound. Treatment is not required unless there are complications or suspicion of a tumor. If it is painful or large, the patient may require an outpatient surgical procedure or sclerotherapy. Hydrocele are typically not aspirated as they can recur. You can read more about this in your textbook on page 772. Follow-up should be at 3-month intervals unless a surgical decision is considered. Post-op follow-up is 2 to 3 week intervals, then 2 to 3 month intervals until it's healed. Referral would be to urology for treatment or to a surgeon. With a varicelle, subjectively the patient will complain of scrotal pain and swelling more often occurring on the left, but this can be bilateral. The patient may have described the scrotum feels like a bag of worms. Examining the scrotum while the patient is standing will result in palpation of engorged veins. When the patient lies on the table, the venous distension may resolve unless a Valsalva maneuver is performed. When determining the differential diagnoses, a good patient history and degree of onset of symptoms will help point you in the right direction. Variceles are graded from 1 to 3. Please see your textbook on page 773 for details of each. To confirm the diagnosis, an ultrasound immunography may show a testicular venous reflex, or thermography may show a temperature increase. Refer all patients to a surgeon. Minor types may only need conservative treatment with NSAIDs and scrotal support. However, more moderate to severe cases and testicular atrophy should be treated. Minor cases or older men may only need conservative treatment with NSAIDs and scrotal support. Moderate to severe cases, those desiring fertility, and those with testicular atrophy should be referred on for surgical options. Follow-up is variable as monitoring of the condition is warranted. Patients may follow up with specialists only for this condition. Complications of untreated varicelle include infertility and testicular atrophy. All patients should be referred to a urologist with diagnostic confirmation to optimize the treatment plan. Referrals to a surgeon as indicated. About 10% of men with testicular cancer will be asymptomatic, while another 10% will present with signs of metastasis. For those who do testicular exams, they may find a hard lump or swelling in the testes. If metastasis is the case, it is usually evident with respiratory and muscular or nerve-type back pain. The clinician may palpate a firm, painless nodule in the scrotum and see scrotal edema. Gynecomastia may indicate malignancy, and hydrocele can form as a result of cancer. Metastatic signs might include lower leg edema due to pressure on the vena cava. Cancer is a solid tumor versus a fluid-filled cyst, and this can be visualized on an ultrasound, so you should perform this first. A CAT scan can be done to assess for any extra testicular metastasis, or if the ultrasound doesn't confirm the mass and your suspicion is still high. Beta-HCG will be elevated in several types of cancer. Alpha-fetoprotein can be greater than 25 nanograms in several types of tumors and heavy THC users. Serum lactate dehydrogenase may be elevated in 50% of cases. However, if all three are elevated, the prognosis is poor. Serum placenta alkaline phosphatase is elevated in up to 40% when there is late disease, but it is also affected by heavy tobacco use. Definitive diagnosis may be made by biopsy or removal of the testes. If the diagnosis of cancer is made, consider a chest X-ray for metastasis. If the chest X-ray is abnormal, then a CT of the chest is recommended and can also be used as a staging tool for metastatic lesions. Testicular cancer is highly curable. The main form of management happens to also be the major diagnostic tool, as the whole testes is removed for biopsy. There is a high rate of infertility after this procedure, so for those who want to have children, it is advised to bank sperm. Cancer staging depends on the type of tumor, evidence of metastasis, serum tumor markers, and lymph node involvement. Please see page 776 to 777, Table 50.1 for staging and classification of the two types of testicular cancer. Combination chemotherapy is used after resection for non-seminomas that have metastasis. Chemo and radiation can be used for seminomas after surgical resection. Follow-up is typically every 3 months with a full H&P and imaging in the first year. In the second and third year, every 6 to 12 months, and fourth and fifth year, every 1 to 2 years. Non-seminomas have a greater than 50% chance of metastasis. Ongoing monitoring is therefore more frequent. There is also a chance of recurrence in the remaining testicle. Referral early to a urologist, and then they will likely refer on to oncology.